Good evening, everyone, and welcome to the Health and Adult Social Care Overview and Scrutiny Committee meeting on the 8th of March 2021. Joe, would you like to go through the housekeeping notices?
Certainly, Chair. Thank you. So, good evening, everyone. Please note that this meeting is being recorded by the Council for live and subsequent broadcast and will be published on the Council website for a minimum of 6 months. In order to ensure the meeting is managed effectively, please could everyone present follow these ground rules for speak when invited to by the Chair. Always turn on your video function when invited to speak, and if you could do this a few seconds before you speak, it will allow the stream to run more smoothly. Please state your name before you speak if you have not been introduced already. Please remember to mute your microphone when you are not speaking. After the committee has heard from officers or presenters, the Chair will ask committee members who wish to speak to use the raise hand feature in the bar at the top of their Teams window. The messaging bar should not be used unless you are raising a point of order or providing the wording for an amendment. If at any point you would like, please use the raise hand feature again, and if you could remember to lower your hands after making your point, that would be helpful. And finally, please remember to lower your hand once you have spoken. Oh, I've just said that. Please ensure background noise is kept to a minimum and that mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you, Chair. I'll hand back to you.
Thank you, Joe. I'm just going to run through the attendee list to save time with everyone switching their microphones on and off. So I'm Councillor Jackie Edwards and I'm chair of this committee. We've got Councillor LJ Evans, who's the vice chair, Councillor Cheryl Johnson, Councillor Diana Butler, Councillor Kieran Wilson, Councillor Chris Matthews, Councillor Mark Robson, Councillor Roberto Rocca. Not sure if Councillor Phillips has arrived yet, and Councillor Andy Jones has sent his apologies. He will be arriving about 15-20 minutes late. Councillor Dwayne Farr, who is being substituted, I believe, by Councillor Fear. Louise Bate from Healthwatch. The portfolio holders, Councillor Karen Rampton, Councillor Nicola Green, and we've got lead member Councillor Hazel Allen, member lead for homeless, and I believe we're expecting 2 other councillors for item 8, and that's Councillor Andy Hadley and Councillor Sandra Moore. Officers, we've got Jan Thurgood, Corporate Director of Adult Social Care, David Vitti, Director of Adult Social Care Services, Sam Crow, Director of Public Health Dorset, Phil Hornsby, Director of Adult Social Care Commissioning, Elaine Stratman, Principal Officer Planning and Quality Assurance, Sally Sandcraft, Director of Primary and Community Care, NHS Dorset, CCG, and Joe Tyler is our Democratic Services and Overview and Scrutiny Officer tonight. We've got Ben Tomlin, the BCP Housing Services Manager for item 7, Stephen Killen, Transformation Director, University Healthcare Dorset NHS Foundation Trust for item 8, Mike Kelly, the Head of Mental Health at Dorset Healthcare University NHS Foundation Trust, item 8. Jonathan Kempton, Programme Manager for this HIP/NHP programme within Dorset Healthcare University NHS Foundation Trust, item 8. If I've missed anyone, I apologise, and can you raise your hand and introduce yourself, please? No. Apologies. Do we have any apologies for this meeting?
We do indeed, Chair. Thank you. As you've already inferred, we have received apologies, and subsequently Councillor Lawrence Fear will be substituting for Councillor Farr for this meeting. And also Councillor Andy Jones will be joining the meeting shortly. Thank you, Chair.
Thank you. Are there any declarations of interests for this meeting? LJ Evans.
Thank you, Chair. Yes, my usual declaration of interest, just that I'm a bank employee of University Hospitals Dorset. Thank you.
Thank you. Councillor Chris Matthews.
Sorry. Thank you, Chair. Yeah, Similarly, I'm a governor of the Dorset Healthcare University Hospital Trust for item 8.
Thank you. And Councillor Cheryl Johnson.
Thank you. Employee staff nurse. Thank you.
Okay, thank you. Anybody else? No. Can we move on to agenda item number 4, the confirmation of the minutes? Unless anyone indicates otherwise, I assume that the committee agrees to confirm the minutes of the meeting held on the 18th of January 2021 as an accurate record. Councillor Cheryl Johnson, is that an old hand? Thank you. Okay. Agenda item 5, public issues. Joe, are there any public issues for this meeting?
There are no public issues for this meeting, Chair. Thank you.
Okay, thank you. Agenda item 6, action sheet. Unless anyone indicates otherwise, I assume that the committee agrees to note the action sheet, which tracks decisions, actions and outcomes arising from previous committee meetings. Can't see any hands raised there. Thank you. Right, we'll move on to agenda item 7, the homeless strategy, with a summary of the health aspects. And I call upon the council's lead member for homelessness, Councillor Hazel Allen, to introduce and present the item. But I must remind the committee that the purpose of this item is to allow you for comments and any questions that will help me in the meeting that will be going to the ONS board on the 1st of April, where the strategy is to be considered in full. So thank you, Councillor Allen.
Oh, sorry, Councillor Allen, you're on mute at the moment.
That's better. Thank you, Chair, for asking me to speak on the health aspect of the homelessness strategy. I'm not sure if I should declare of interest, as I'm just a speaker and not a member of the committee, but just to say that I do have an interest in this area, as my day job is, and just for transparency, nurse in liver disease for the whole of Dorset. And there's a couple of items that I'm going to be mentioning in this overview that I do actually have line management overview of within my job. And one of them is the hospital-based homeless care service, which we recently started. And also I'm involved in the Dorset-wide hepatitis C elimination programme, which again links in with healthcare around people that are experiencing homelessness. Just to give you a little bit of context. Okay, so I've been asked to speak particularly around part 4, the impact of the COVID-19 pandemic, and part 6, which is our core aim 3, particularly around health and well-being focus. And I'm also going to mention one item in our draft action plan, which again is all related to health. So I was reading the strategy again over the weekend, and I noted 33 references to the word health within the strategy, which clearly shows that there is a focus on health and well-being, and that it's a core aim. And I think that's because unfortunately there is a clear link between homelessness and poor health. Poor health can lead to an increased risk of homelessness. Health can be affected by the risk of losing your home, people losing a job and unable to work, particularly with a long-term health condition, can lead to homelessness. And sadly, this can be exacerbated by mental health, that feeling of constant anxiety and pressure, conditions such as stress, anxiety, and all these can lead to a greater risk of homelessness. BCP's demographic information, this shows that this is a very common factor in all homelessness and homeless applicants, and in particular mental and physical health problems, and this makes up 45% of the total of applications, so that's quite significant. Homelessness is individuals sleeping rough, and this is often sadly related to substance dependency, and long-term rough sleeping can lead to vast vastly reduced life expectancy, on average 46 years, and even less for a woman of around 43 years. You know, having an impact on health around a homelessness strategy, I mean, you're talking about potentially saving lives and avoiding premature death. So there's numerous risks of, if somebody is sleeping on the streets, there's assault, prolonged exposure to cold and damp, overheating, dehydration, lack of a balanced diet, the stress and worry and mental distress of just coping with that environment. And sadly, when you're looking at substance misuse, there's the risk of overdose and bloodborne viruses, and also related infections from injecting of drugs, etc. So there's additional health issues that you see in this group that is much more acute than you would see in the general population. So to help an individual that's experiencing homelessness and may also be sleeping on the streets, to move off the streets to gain and maintain a secure tenancy and to move on with their need to have a holistic, coordinated, wraparound care that meets all their complex, interdependent and interrelated needs, and health services that is essential for this. So you're not just talking about physical health, you're talking about mental health, you're also talking about drug and alcohol services and social care needs. We also need to look about the wider well-being of individuals. So we need to meet other needs like their housing needs, their financial needs, claiming benefits, debt advice, access to simple things like food, toiletries, clothes, shoes. And hopefully once you've got somebody a bit more stable, you want to look at skills training, meaningful activity, supporting to work, and a place that, so it's you have to look at the whole person, not just health, but also well-being, which is obvious. This can be a very slow process, and what services need to do to even get people to access services is to build trust. Often these individuals have very little trust of what we would consider mainstream services. It takes time. You need to hear their story. You need to meet their initial needs and then gradually help them to move forward. And I also think it's very important that you have a safety net and a flexibility within the systems that you're working with, so that you can escalate support when an individual that's been stable for a while starts to struggle, so you can catch them before they fall, and you can stop that cycle of homelessness and that returning to the streets. So BCP region have a numerous existing health services that respond to this large critical need. We've got the health bus, we've got bloodborne virus community services, we've got specialist substance misuse workers. As I mentioned at the beginning of my presentation, we have a new hospital pathways team in Bournemouth Hospital, and we're looking to hopefully roll that out across Portal. And that's a team of nurses and care coordinators that particularly care for people that are coming into the hospital and admitted to the hospital that are either abode but are at risk of homelessness within a 3-month period. But what we need to do is focus on enhancing that joined up approach and also linking in with housing as well, because obviously we know the important aspect of all of these things, but certainly not the only one. There are still currently some issues around access, and there's also some issues around people accessing care that are in temporary accommodation or that are in what we would call vulnerably housed. And it's very important that we have a joined up approach and a joined up needs assessment, so that we can review and improve the provision. And what we really need this to be part of the key role of preventing homelessness and resolving homelessness and coming up with sustained solutions. So we need to have close working of prevention services, housing and health, to ensure that people can access health interventions and treatments when they need it. We need to focus on people that are sleeping outside because of the health risks involved in that, but also households and families that are at risk of becoming homeless, those that are in poor quality or insecure accommodation, and enabling them to access other wider services, so that well-being, not just around health. This work includes further developments of pathways, and I'm involved in a big piece of work around an out of hospital model, which looks at the provision in primary care in the hospital, working alongside the housing services, and we've got a new dedicated team of housing options officers, and all this work is ongoing in the background. We're looking at trying to make sure that we assess frailty and have robust holistic assessments, and that information is shared so that people aren't having to give over that information over and over again. And this is a significant focus because it's potentially not only helping with health, but it's reducing homeless related death, including dying from suicide, from poor health, and from being victims of crime. And we need to ensure that these systems are in place so that there's no significant barriers to health provision and people can access GPs and dental care. So it's holistic, it's proactive, and it's proper packages of care that are tailored to support. So as I said, I was going to mention how the COVID-19 pandemic has impacted and shaped this work, and it has had an amazing impact, because what it did is it basically pushed a lot of those services together and made people work more collaboratively in a more joined up approach. This is under the umbrella of the Homelessness Reduction Board and the Homelessness Action Groups, and we have a health action group. And it definitely accelerated and galvanised these partnerships and approaches, and it successfully brought together some really good outcomes. That's actually put a positive focus from central government on BCP. They're looking at how we're working. They know that health is a big part of that, and they're very impressed with that. And that has actually brought some really good funding to BCP, which is great. And it's also brought a lot of good to our partners because of that collaborative work. And it was very hard work. People worked very hard through the pandemic. So in the past year, with dealing with COVID-19, health partners definitely were working much more closely together. But unfortunately, I think that that's slightly moving apart again, and we really need to work hard to create that sort of more multi-agency, multidisciplinary working. So these are the commitments that we mentioned in our core aim around health. And we really, what our plans are to try and actually bring some actions forward for this principle is to have a multi-agency, multidisciplinary working, and for us to have lead clinicians, so that we have someone that leads that team, and have an MDT approach where you would have a lead practitioner depending on the person's main need. So it may be that actually housing might be their lead because that's their main need, or it might be the mental health side or physical health. So it's about everybody being involved in that person's care, but having a certain lead for it. We're also looking at that all those health partners that are employed by lots of different people, lots of different bits of funding here and there, it's a little bit disjointed, but to hopefully have them co-located and starting to work as more of a multi-agency, multidisciplinary team, so you haven't got individuals out there working on their own without that good governance structure, and so that we can really focus that work together and build on the amazing work that we've actually seen during COVID-19. Already we've got some additional funding for drug and alcohol provision around the homeless services. We're going to get some more mental health staff. We've increased GP sessions and nursing sessions, and we've also got some social care provision coming in. So there's a lot of resource coming along, and that's why it's really important that we work together as a multi-agency team. Otherwise it could be a bit disjointed, and eventually we need to unpick all that, and we need to look at funding a proper service. That's my hope for the future, because there are primary care provisions around the country. We've got Southampton, Brighton, Bristol, Exeter, London, are dedicated primary care provisions for those experiencing homelessness, and I think that's what we need to aim for in BCP. And then just going back very briefly to the out of hospital model. We're one of the very few councils that have actually been selected to develop a model of out-of-hospital care. So that means that when somebody comes into the hospital, they are looked after by the homeless care team, but then when they're discharged, they're handed over hopefully to that MDT teams who can follow up their care post them being in hospital, make sure that they finish their antibiotics, have their dressings, have everything sorted out so that they're not coming back in with the same acute problem. And then hopefully you don't have that frequent attenders in, and that's obviously has a good knock-on effect for the hospital. Costs primary, secondary care is very expensive, so it's about admission avoidance, and it's about trying to deal with those things that really should be dealt with in primary care, which should, for example, an infection, getting on antibiotics quickly, rather than someone coming in acutely ill into hospital with an infection that could have been dealt with in primary care. So we really need to work to look at that. And then we also, I feel, for the well-being point of this, is we need to develop services that give people a feeling of community, that they can be involved in social enterprise. And one of the examples of that is Stay Safe, which is a development of the Sleep Safe, where they're allowing people to go to a location and be involved in activities. And I think that's really important if we're looking at the wider well-being and the greater needs, the need for purpose, the need for friendship, the need for community. So within the action plan, this is what we've already sort of put together within the action plan that's still a draft at the moment, is to develop and plan a multidisciplinary team, including health partners, and ensuring a whole-scale approach of safeguarding health and well-being of individuals, including early interventions. So we have better health outcomes with a quicker diagnosis and issues leading to fewer and shorter hospitalisations, fewer escalating issues, fewer life-changing complications, such as somebody requiring amputation of a limb, fewer early deaths, and better well-being and mental health. Thank you.
Thank you very much, Councillor Allen. If we can do the questions in two parts, and that's one, those who have got questions specifically for Hazel on this, and then second part, any questions that you want me to take away to ask at the overview and scrutiny panel. So can I ask if anyone's got any questions for Councillor Allen, please?
And also call as well if there's any questions for him. Thanks.
Thank you very much. Councillor Wilson.
Cheers, thank you. Not really questions, more comments. I think I want to really commend all the work that Councillor Allen and everyone has put in recent months, but also going back to the start of the pandemic. There's been a lot of really successful work that Councillor Allen touched upon in her introduction. And I think that should really be celebrated. I think, what I like about the strategy is the honesty, it kind of, it puts out in black and white the reduced life expectancy of somebody sleeping on the streets, and I think that's really important. It states that it is literally a matter of life and death, which it is, and I think that's why we wanted to bring it here to the committee to kind of see it and kind of talk about it and discuss it, and it is really important. I think the one thing I might say, and it's not a criticism as such, but it's more of a comment to just an error of caution, is that there is a lot of focus on rough sleeping, and rightly so. That is the most extreme part of it, but it's just not. And Councillor Allen did mention in her opening around the more general kind of housing insecurity and homelessness and temporary accommodation, but it is just to make sure that isn't lost at all, because that is really a huge part of it as well, mental health and the health of families in these situations. So no, I think the work that's going on is really fantastic. I'm looking forward to seeing the action plan and getting that captured, all the stuff kind of in a document. But no, really just to commend the work.
Thank you.
Can I just comment, please?
Yes, thank you.
I just wanted to say that I feel very strongly that actually we've done very well with bringing people in, and actually we have a much lower number of people that are rough sleeping, which is amazing. But no, if we want to impact people's lives and help them to move away from homelessness, which, as you know, takes a long time. This isn't a short fix. Some people move on quickly, but others with more complex needs move on more slowly. And actually, it's really, really important that the health provision is not just for those with rough sleeping, and actually it is for those that are vulnerably housed and temporary housed and in supported accommodation, because they don't access primary care provision like the rest of us do. They don't, and they really need that bespoke provision until they're in a point where actually they can easily get access to their primary care. And I think that's really important. And actually, some of the health services are very targeted just on the rough sleepers, which I don't think is wrong, but I think that provision's got to be broadened right out. And I don't think you want just a nurse to do rough sleeping. It should be experiencing homelessness. And I feel really strongly about that, Kieran, and I'm going to really push for that to be the focus, because it is the sharp end, the rough sleeping, but actually if you don't get it right across the board, you'll end up with more people rough sleeping. So, but thank you, and I just want to commend Kieran's work, because he's done a lot of good work around this, and we're always in meetings together, and we share a lot of passion for this. So thank you.
Thank you. Councillor LJ Evans.
Thank you, Chair. I've got a couple of questions about the strategy for Councillor Allen, and then a couple of questions on the Healthwatch report, which I don't know if Louise Fate would like to come in on. Yeah, absolutely echo Kieran, what he said. Amazing work. Thank you so much for that. I just wanted clarification. Are we still looking at using the housing first model? I couldn't see it mentioned specifically in the report, but I may just have missed that. And my second question for Councillor Allen was about the MDT community hubs. Sounds like a great idea, but I was just wondering if you could provide a little bit more detail on those, please.
Okay, I wonder if Ben would housing first model. Ben, are you on the call? Thanks.
I can answer that. The housing first model that's delivered in Bournemouth and Poole primarily at the moment is included in the action plan. The detail about maintaining and actually upscaling the provision is really important. Housing first service that's worked really successfully for a number of people over a number of years, and we hope to extend that. Yes.
So, so the idea of a community hub where we would not just have all the services co-located, which actually, when you look at other hubs around the country, you could argue that that's one of the biggest benefits is just the co-location. And you'll know, LJ, if you can walk across the room and have a conversation with your colleague, it takes 2 seconds, and then you know exactly where you are with that patient. Where if you're all scattered around, that lack of communication, the right hand doesn't know what the left hand's doing, and you don't get that coordinated care. So I think the co-location of the health provision, which it's not a infinite provision, I think we could possibly even increase it. So the co-location of the team together in one place, I feel very passionate about. I also want to see basically what would be a primary care sort of provision, but expanded to include housing and all the other services basically under one roof. Is something that we're health providers about, and we've got some plans and ideas, but it's not finalised yet. So so watch the space with that, but it's something that I would really like to see happen, because I just think having everything under one roof with outreach to make sure that it covers the whole area is I think so that hub and spoke model I think would be great, and we can use the Health Bus to do that, but it's still a work in progress. It's lots of different partners, as you can imagine, so it's challenging to get everyone to the same place.
Thank you so much for that. Just roughly, how many community hubs would we be looking to set up?
We would probably have one location, but with outreach into other places that would be considered hubs, places like Roots to Roots in Poole, where you've already got a sort of broader hub type provision. And I've been talking to them about trying to make sure that ideally in their new build that they have a clinical space, so that you could then come and use that clinical space and do in-reach into that. So that would potentially be a hub. Then you may be going into supported housing provision, or where there may well be somewhere where you could do some clinical, again, a clinical space. So you could consider that hub. And I would like a co-location for all the staff that would be, say, maybe the central hub and spoke. But I don't think we're going to necessarily have lots of individual places that just do health. But I think we would see them in reaching into places which are already sort of naturally hubs around the area.
That's brilliant. That sounds really exciting. Thank you. If I may, Chair, move on to the Healthwatch report.
Can I just interrupt there, Councillor Evans? I'm aware that Councillor Allen has to be somewhere else very shortly. So are your questions, could Louise Bate answer them in the healthcare part of our agenda?
Well, they're related to the homelessness strategy, but yes.
Okay. I'm fine. Okay. My team's up for an award tonight, so I want to see the
on yet.
Yeah, in virtual world you don't have to wear it. It's great.
Okay, yeah. Thank you, Councillor Evans. Yeah, absolutely your questions.
Thank you. So yes, moving on to the Healthwatch report, mental health in the community. First of all, Louise, I thought that was an amazing piece of work. Also, I love the way the engagement was done. It was 100% recognised. You can't just go in and ask people you've never met personal questions about their lives and how they've ended up sleeping rough and all sorts of things, but actually went in and helped prepare food and all sorts of things. So I thought that was truly fabulous, and yes, all credit to your engagement officer. Came up with a number of recommendations, all of which I absolutely agreed with, especially with the issues around community mental health often being closed to people with substance misuse. Mm-hmm. I understand these have been passed on to the CCG, but I wanted to know how are we going to ensure that these are both implemented and also that they are monitored, so we know that improvements are made. Thank you.
Thanks, LJ. You're right, always the tough bit. But I've actually got a meeting next week with the CCG to talk about, and we'll carry on following that up. And we've actually also been successful in a bid for a piece of work to create some case studies around the people that we've been working with to look at people's experience of homelessness. So that also enables us to kind of follow up on this work over the next few months. So yeah, I hope that answers your question, and thank you very much.
Thank you for that, Louise. Next person I can see with our hand up is Councillor Diana Butler.
Thank you, Chair. I wanted to say access to information. Quite a few people who have problems find it very difficult to actually admit that they have a problem. Do you think, would we be able to use libraries and use for people to pop in and ask who they could contact as a sort of one option, as a more informal option? The other thing is, could we encourage landlords, as housing is a big problem, could we encourage landlords to keep rents lower, also give them other incentives, maybe even cap rents, because they're getting to a ridiculous stage now in this area? And the other thing is places of refuge for people who are being abused or do not feel safe at all. Would there be possibility, especially for the council, to have places built, maybe specially for that reason? I know years ago we used to have homes for especially for homeless mothers with babies. So, you know, something like that could be something we could maybe look at providing in the area.
Okay. So what was the first question? Sorry, because I've quite a few questions there. Oh, you're on mute, sorry.
It was access to libraries as possibly being for.
Yeah, so I'm not as involved with the sort of plans that are going forward with other one of our other lead members around this, but about what is our customer access points BCP, and Jane Kelly's leading on that, and I think that's sort of general information about where you can get support if you are facing homelessness, if you think that you're likely to be losing your hope for that would be somewhere that you could access, and they are looking at our access points being in the libraries, but I don't know how that works developing, so that might be something that would be worth discussing with Jane. So what was the question?
And the other one was maybe capping rents and trying to find incentives for landlords to provide accommodation on a longer term.
Okay, I might ask Ben to come in on that one, if he's able to.
Okay, and the third one was about places of refuge. Maybe the council might be able to provide buildings especially for that, for vulnerable people.
Yeah, again, I think probably Ben's able to answer those questions a little bit better, if that's okay.
Okay.
So with reference to the landlords and capping rents, I don't think the council has the ability to cap rents per se, but we do have a number of incentives and support arrangements, particularly for private. We offer grants and support to landlords to help them manage their tenancies. So it may be that we would exchange a grant or a small grant to do some work around a boiler or some repairs in a particular property in exchange for a long-term let of somebody, for a family that needs a tenancy on a long-term basis. So be really successful in listening to some private landlords around what they need in order for us to sustain longer-term tenancies, particularly in the private sector. So that's been reasonably successful. As part of that condition, the landlord has enabled us to keep rents at a reasonable market level for tenancies to be maintained. With respect to the places of refuge, the council commissions a number of housing related support services for both single people and families that have additional support needs. So in addition to a provision of refuge for victims of domestic abuse, there's other provisions for housing related support for people with drug and alcohol misuse, mental ill health, and people with learning disabilities, for example. So there are a number of specialist provisions out there already that provide a really excellent service for people that are threatened with homelessness or unfortunately need emergency or some more supported accommodation.
Thank you.
Thank you, Ben. Councillor Chris Matthews, is this a health related to the homeless strategy question, Chris?
It's not actually. I was just going to comment on the report from Councillor Allen because if that's okay. So I think it's an excellent piece of work, and I'd like to congratulate Councillor Allen for, clearly. Sorry, I'll put my camera on a moment as well. Clearly for the dedication and passion that's gone into it. What I really think is brilliant about your presentation this evening and the work that you've done is it's very honest, as Councillor Wilson said. It's really taking the issue sort of head on, and we're treating it honestly and proactively, and that's what it's all about. So I suppose one concern I suppose I had, and I'm not sure if this is a question that you can answer, but I just think one of the issues that homeless people have is they're demonised, and that is a major kind of issue to overcome. And I'm just kind of wondering how we kind of bridge that, how we mitigate that, because clearly people coming forward for health purposes, if there is this kind of tension towards people who are homeless and they feel disconnected in any way, but that's really difficult to work. So I suppose that's my one concern really. And as I say, the great work that you're doing is fantastic, but it's almost like we need something else as well to kind of break that kind of social taboo as well.
Yeah.
So yeah, no, that's what I wanted to say, but thanks.
I think reasons why I guess I feel that we need a bespoke service for people that are not just currently possibly rough sleeping, but have very recently been rough sleeping. They're very wary, they don't trust, they don't have the patience to sit and wait, they find that whole situation stressful. How would you up to an appointment at a hospital with all your stuff in a backpack, maybe not very clean because you've been sleeping in the night and you haven't been able to, you're probably not going to get there, the stress of just getting on a bus and getting there, the anxiety, etc. So I do think that we do need to offer that, because then you can get, but it's really important that you get the welcome right, so that people made to feel welcome when they first come in. Maybe all they do is have a chat and a cup of tea and start to tell their story, and they might not even know that they're already being assessed, but they're not aware of that. And then have a triage and start to get, why don't you come to the doctor? And actually I think health is quite it's a good neutral start open up to other services, because health's often the thing that's really acutely they need sorting out. But then once they trust you from the health side of things, then they might talk to the housing person, because it's like it's a way open. And there is terrible, I agree, there's terrible stigma around homelessness, there's terrible stigma around drug and alcohol addiction. I work in bloodborne viruses, terrible stigma around things like hepatitis C, and people do demonize, and they're, you know, what do they say, everyone's a couple of life-changing events away from being homeless, and you know, it's very difficult. And I think that if you can help build confidence, and that's why that well-being stuff's not just about health, it's about well-being. If you can build people to build relationships, then they can start to move back to what we would more see as what would be considered a sort of a little bit more of a structured life. But I don't know what the answer is, but I think getting the services right and helping build that confidence so that they can deal with some of that stigma is a way forward. But it's difficult. It's difficult.
Thank you.
Thank you very much. I can't see any more hands, so thank you. Oh, Councillor Wilson, is this a quick question?
Very, very quick. Sorry. It's just following on from Councillor Matthews' point and Councillor Allen's there. Do you think then we need something more explicit within the strategy around dignity and around kind of, you know, kind of trying to tackle stigma? Do you think we need something? I don't know. It's just a question.
So it's a good question. It's an interesting one. I think that we probably need to perhaps discuss in that wider partnership in the form of some of the action groups. And I'm just trying to think where that but maybe the Move On group, I don't know. But I think you're right. I think there is an issue around stigma, and there is an issue around people treating, I mean, we've seen those programs where someone says if they sit on the street, nobody sees them, they walk straight past them, it's almost like they don't exist. And I'll often that's sometimes because people just don't know what to say, they don't know how to help, they feel awkward, they feel embarrassed, it's awkward. So yeah, so I don't know, I think it would be interesting to maybe explore that a little bit more, and it is something that we could think about including. Yeah, so yeah, it's a good idea.
Thank you, Hazel. Councillor Mark Robson, is this a quick question?
Yeah, very quick. Not so much question, but I agree with those last three things. I don't know whether it sits in the strategy, Hazel, whether it sits in the action plan, but I think there needs to be some sort of flow chart there where we can follow that through, and I'm sure this will come in the action in order to track all that and capture those very important points that have just been raised. Yeah, I absolutely agree.
Thank you. Thank you very much, Councillor Allen, and you enjoy the rest of your evening. Let us know if you win.
Okay, thank you very much. Thanks everybody, and thanks Chair for inviting me to speak, and I'd just like to thank Ben for sitting in as well and answering some of the questions.
Yes. Thank you, Ben. Yes, yeah.
Thank you very much.
Yeah. Right. Joe, I believe you want a very quick word.
I do indeed. Thank you, Chair. It's just Councillor Susan Phillips has informed us that she sends her apologies for this meeting, so she will be absent for this meeting this evening. Thank you very much.
Okay, thank you, Joe. Moving on to agenda item 8. This is the Dorset ICS New Hospital Programme Strategic Outline Case. And if I can call upon Stephen Killen, the Transformation Director of the University Hospitals Dorset NHS Foundation Trust, to present this item. Can I just remind everybody, this is just an information update. Thank you. Thank you, Stephen, if you'd like to, and you should all have seen the presentation slides as well beforehand.
Thank you, members. I will just share my slides for about 8 to 10 minutes while we talk to, and then we'll take questions as we'd agreed, if that's okay. Hopefully, Chair, if you can just confirm that my slides have come up, if you can just nod.
Yes, I can see them.
Thank you. Okay, so thank you, Chair. Thank you, members, for hosting us this evening. We wanted to just take a few moments to just introduce the team. So you've got myself, Steve Killen. I'm the Transformation Director for University Hospitals Dorset, but I'm wearing a hat that is system-wide for the Dorset system today, talking about the new hospitals programme. I've also got Mike Kelly from Dorset Healthcare, who is the Head of Mental Health, and Kempton, who's the Programme Manager from Dorset Healthcare, leading on this health infrastructure programme and the new hospital programme. And really, this is a good news story. So it's an opportunity to come and present to you and reaffirm Dorset's position at a national level, the positive and the opportunity that's presented to us, which looks like it will present a £350 million capital opportunity for us. But really, I just wanted to spend a minute or so just refreshing for any new councillors of what was the clinical services review, also called the CSR, that was run by the system back in 2017. And the reminder was this was about better care and improved pathways. It was about delivering access, and had gone through extensive scrutiny. So it had gone through consultation, judicial review, an independent review panel, and then the Secretary of State. What it found is that Dorset is a really credible system, both locally and nationally. In fact, we are one of the, in terms of healthcare and join up with local authorities, we're in the top 10 systems in the country. In fact, we were one of the Wave 1 integrated care systems. So the clinical services review really put several things at the heart. It put prevention, it put community investment. It was all about acute services, and they may have got a lot of the media attention previously, but this is about putting community services at the heart of the real change in our system and putting care closer to home. And whilst the early Wave 1 investment did give £250 million into our system, and that was for maternity, children's, emergency and critical care site on the Bournemouth site, and the most advanced theatre complex in the UK is being built at Poole Hospital on the south coast, and investments in pathology, there was still the opportunity for improvement in the community. And this opportunity that I'm talking to you about today, called the Health Infrastructure Plan, is really that opportunity to deliver that community change. So what is the Health Infrastructure Programme and the new hospital plan and the new hospital programme? It was the government strategy in 20 infrastructure, and the programme came up with 40 new hospitals called the Health Improvement Programme. That manifesto, the Conservative manifesto, put that programme at the heart of their change gender within health, and we had 12 of the hospitals in the 40 in the Dorset system. Following a bit of a review and a prioritisation, they tweaked those 40 hospitals, so we are still maintaining that those 12 are going to be delivered in the Dorset system, but 5 of our 12 are prioritised. So 5 of the 40 in the UK were prioritised, and that was going to bring in the opportunity for up to 350 to 500 million still to be worked through as an opportunity for investment in our Dorset programme. So that's the kind of the hospital programme. What did it for Dorset, and I'll just very quickly cover Dorset. It was an ambitious programme that covered mental health, community beds, and expansion of what was the clinical services review. But if I focus particularly on BCP, it was about developing all of our hubs in our area. And I'm going to come on to Mike and Anne's, but briefly, the health new hospitals programme for Bournemouth Hospital was all around beds, wards and refurbishment, and it gave about 48 beds in the Bournemouth site and about £90 million. On Poole Hospital, it was about wards, theatres and beds, and was about 50 to 80 million pounds and 72 beds. And then both, and I'll come to Mike actually. Mike, if you just want to jump in and talk about some of the work we're doing around the mental health for a minute or so.
Yeah, thanks, Stephen. So just the HIP2 programme, there's 3 mental health schemes part of this programme, and the HIP2 is a great opportunity to kind of build on the acute care pathway review that was consulted and completed in 2017. And as part of the, I'll call it the ACP for short, there was extensive modelling done around patient flow over a 5-year period. And we looked at demand, capacity and provision of beds across Dorset. Now, in the national benchmarking work that's undertaken every year, Dorset has a lower bed base for adult acute beds and comes in the lower quartile per 100,000 population. So we've got 15.3 acute beds in comparison to the national average, which is 18.8. So the modelling identified that there was too many acute mental health beds west of the county and not enough in the east, where there were higher levels of morbidity of serious mental illness and greater demand for beds. So the outcome of the consultation and review decided that there was a need to close the Linden unit in Weymouth, which has got 15 acute beds, and move them to the east of the county, to the St Anne's site. And on top of that, the review identified that there was an additional 16 acute mental health beds needed. So 4 additional beds needed to go into the west of the county to meet that need, and 12 new beds needed to come to. Then the second scheme then was around CAMHS PQ, and there was several national reviews undertaken in 2017, one by CQC, which looked at young people accessing CAMHS services and identified there was long waiting lists and an imbalance between the demand and capacity for inpatient care. So young people were not able to access an appropriate inpatient bed locally. Specifically, the CQC identified that access to young people's psychiatric intensive care beds was a significant problem. And then the National Tier 4 review in 2017 identified the low bed base, especially in the south of England, around CAMHS psychiatric intensive care beds. So in 2018, NHS England approached Dorset Healthcare to see if we would develop an 8-bedded CAMHS PQ because they felt that Dorset Healthcare was best placed to develop this because we had an outstanding CQC rated CAMHS PQ or CAMHS General Adolescent Unit in Pebble Lodge, which had also got an education provision which was rated outstanding by Ofsted. So this CAMHS PQ provision would provide psychiatric intensive care beds for young people for Dorset, Sussex, Hampshire and Isle of Wight. So unfortunately in 2019 the Trust was unsuccessful with a planning application to build the PQ on the Allenhurst Road site, but fresh plans are being drawn up to resubmit the planning application. And then the third scheme as part of the HIP2 really is the redevelopment of the Forston site in Dorchester, which would be a rebuild of the Waterston unit, which has got 18 beds, but does not meet CQC or Royal College of Psychiatry standards, and the Mellstock unit, which has got 12 beds, older people, functional beds, which originally was built as an admin block, really, so it wasn't built for providing clinical care. I'll pass you back to Stephen then.
Thank you, Mike. And then, Chair, 2 more minutes, if I may. So Christchurch was then around hospital, BCP was around reconfiguration, and then there's a couple of pictures on the side that's showing how we're already starting to make some of those progress around the kind of backlog and the infrastructure. But this is an opportunity, as I said, for great investment in the Dorset system to continue the work that we've already started. So a couple of final ones. What is a community hub? Well, it can be whatever the community needs it to be. It's going to be place-based, and we have the opportunity to define that. It could be a shared space based on whatever is needed in that area. Could include rehabilitation, inpatient and outpatient. Could be clinics, or could also be a base for local authority or third sector and primary care to work together in offering services into the community. And it was interesting listening to Hazel's comments before about opportunity for hubs, and maybe that could be a future opportunity in join up. In terms of just giving you an idea of the programme setup, it truly is cross-sector. It's got a sponsor, and the SRO is the Chief Exec of Dorset Healthcare. We've got representation from all the board members from all organisations, including Sally from the CCG, who's on this call. It is going to be a number of 5 schemes. So as shown at the top, we'll initially submit the 5 schemes for Dorset County, St Anne's, Bournemouth, Poole and Christchurch. We will be writing the programme that also includes the other community hubs, and you'll note Wimborne is on there now. Wimborne is clearly Dorset Council, but also we do have a number of BCP residents who probably access that service, and that will include some investment in the Wimborne area. A number of key risks that the programme are managing, which you'd expect us to track and manage through. Final thing just to say is that the programme does have fit with the wider strategic Dorset programme in terms of the assets that we're developing. But the programme also has a drive from a national level to have sustainable infrastructure programme, and really 2 measures for that. One is called Modern Methods of Construction. That's about how you can do as much off-site improvements as you can, but also investing in local supply chain to help with that. And we've been working with the local, both with the council and the Chamber of Commerce, around how we can kind of get our supply chain and local partners involved in that. But also there's a drive for something called net zero carbon, and that's about whole life running costs and carbon reduction, really. So they're kind of also sitting at the heart of it. In terms of why I'm here, really it's to say that we've submitted this business case to the NHS England and NHS Improvement on the Dorset clinical strategy. It's supported by all partners in the Dorset system. Next steps are to take it through. It is an outline case at this point in time, but part of this is to keep the HOSC aware of it, as we had done through the clinical services review. This is kind of beginning of the next phase of that journey over the next decade, as we start to hopefully draw this opportunity for up to £500 million worth of capital into the Dorset system. And really it's to say I would like the Health Oversight Committee to recognise the good news and support all of our units and endorse them where appropriate, but to also note it is the beginning of a journey, and hopefully, Chair, we'll have the opportunity to come back as we progress our cases and as we move them forward. We get the chance to come back and talk to you again. So I'm going to stop screen sharing there, and thank you for your time.
Stephen, thank you, Mike. Very interesting. Good news for our area, all that investment in our local hospitals and the community hubs. Have any committee members got any questions, please? Oh, you're going to be let off lightly there. I think, yes, it would be a good idea. Possibly if you come back to us when you think it would be a good time to sort of come to give us a review onto how you're getting on and how your report went down with the sorry, who were you sent?
Well, it's gone up to the NHS national team, and ultimately we'll go to Treasury for approval, and then we'll come back down. So quite happy to come back in kind of 6 months or so and give an update. Okay,
yes, thank you very much. So if there's no questions, can I move on to agenda item 9, which is the Healthwatch Dorset draft work plan. And if I can ask Louise Bate to present this. This is an information update for members, and if you would like to reserve your questions till after Louise has presented it. Thank you very much.
Thank you, Chair. Yeah, thanks for inviting me. So it's this time of year when we look back at all the feedback we've gathered over the year and kind of set our work plan for the new year, starting from April, to talk to you about our draft work plan and get your thoughts on it, really. So if I just run through quickly the work plan items we're suggesting that we work on. Our main project for this year is going to be around children and young people. So we did quite a lot of work last year looking at the CAMS review, and we did a lot of engagement with marginalised young people. And I think one of the key things that came out of that project for us was that we need to be more proactive about the way we listen to young people. So we've developed this project called Young Listeners. They're going to be a group of young people aged between 16 and 25 who we will support and provide training for. We have a youth worker who will support them over the summer to develop their own engagement programme where they go out and find out what young people think about health and social care across Dorset. We ran a recruitment programme in January and February and had a great bunch of applications in, and we've just formed the group and we've got 13 young people who are going to be on that group. They're fantastic. I was really blown away by their enthusiasm for the project and their how eloquent they were about why they wanted to take part in it. So really looking forward to the next part of that, where we'll provide them with training and support and then help them design their own engagement programme. It should be really exciting. The other kind of main project for the year for us is going to be around access to primary care. This was one of our work plan items for last year as well. And I think some of the things we were going to work on, we had to change because of COVID. But actually, we were very successful in the way that we kind of changed our work plan last year, and it made sense. So this probably virtual consultations quite a bit. We're really conscious that there are a lot of people who still aren't accessing primary care because they're worried and they don't want to bother them. So I think a big part of our work will be looking at how can we make it easier for people who can't use digital technology to access primary care, and just make sure that people are contacting their GP when they need to and using primary care when they need to. So we've got some research to do on that. We'll also be thinking about carers, people with learning disabilities, looking at annual health checks, so health inequalities for people and accessing primary care. We've done quite a lot of work around accident and emergency care. So at the end of 2019, we worked on a national project that helped inform the national review of A&E performance measures. Since that report, the recommendations that we had made, that things have changed quite a bit because of COVID about the way A&E services are provided, and the NHS has launched a project called 111 First, encouraging people to contact NHS 111 before they visit A&E and effectively make an appointment for their visit. So in order to find out how the service is working at the moment, we've been working with Poole Hospital, and they have been sending out text messages to people who've been through A&E in January and February, inviting them to have a phone chat with one of our volunteers. And I think at the last count, we've done 120 phone interviews with people over the last 6 weeks. Our volunteers are really enjoying the project. We gave them training and to carry out these phone interviews. So I think we're probably going to run that for another couple of weeks and then look at where we are, see if we've got some clear themes, and then report on that project. And then the plan is to kind of tweak that, take some learning from what we've done so far, and then adapt it in order to run a similar project at Dorset County Hospital in the summer. transport is going to be one of our focuses this year as well. This is a key theme that people talk to us about, and was another project that we planned to work on last year, but then COVID hit and nobody was going anywhere for a while. So transport didn't seem like the best work plan item for last summer. We've just recently launched a survey to gather people's feedback about the vaccine. So we want to know what's working well for people about accessing the COVID vaccine, and what could be improved about it. And one of the questions in that is around transport, because we've had inquiries from people who are worried about how they get to have their vaccine. There are some people who've been effectively kind of shielding for a year, and the thought of going outdoors is a bit scary, let alone how to access transport if you don't have your own car. So I'll be really interested to see what people tell us through that vaccine survey, and that will kind of that will help us focus that piece of work. We've also working on a commissioned project with Wessex Cancer Alliance and Wessex Voices. So that project's funded by NHS England and NHS Intelligence, and we are developing some creative engagement tools for children and young people who are living with cancer to gather their feedback over the next few months. And that project runs until June. I think the other thing to add, we've left ourselves enough scope within this work plan to work on other projects that come up throughout the year, because last year we had to be very adaptive because of COVID and change what we were going to do in order to be relevant to what local people were telling us. And we see the need to do that again this year, because things are changing all the time. I think one of the things that people talk to us a lot about is dentistry. And we're quite conscious that we don't have, there's not a lot that we can change about that locally, but what we can do is input to Healthwatch England, try and improve dentistry at a national level. So there are some work plan items that we'll be working on in the background to kind of have an impact nationally, where we see that we probably aren't the right people to be making an impact locally. I think that's everything. If anybody had any questions about those or any suggestions for others you think we should be looking at, I'd be really keen to hear them. Thank you, Chair.
Thank you, Louise. You always pick some interesting topics for your volunteers to look at, and most of them, if not all of them, affect most of us, and if not our residents, or all the topics that you have. So Councillor LJ Evans, you have a question.
Thank you, Chair, and thank you, Louise. So there's some really exciting things coming up, and personally I'll obviously be really interested in the access to general practice and patient experience for that. I think you mentioned when we last met that you're going to be looking at the COVID vaccinations and possibly views around vaccine hesitancy. I just wondered if you could say a bit more about that, please.
Yeah, so thanks, LJ. We've launched a survey, sent out a press release today, actually. I can add the link to the chat for anybody. I'd encourage you all to fill it in and share it, please. The more feedback we get through that survey, the better. I know the CCG are very keen to gather feedback about people's experience and impressions of the vaccine. So yeah, thank you. I'll pop that link in the chat now so I don't forget.
Thank you. Councillor Mark Robson.
Hello, yeah, I know you're waiting back for the replies regarding transport and stuff like that. But I was just wondering what transport was. How do you see that going? Or what do you think might be the best solution for that?
I think that there are a number of community transport schemes that Dorset used to have. A lot of small, very local community transport schemes that, because of COVID, it's had a real impact on that. Obviously, like I said, people weren't going anywhere, but a lot of the volunteers who volunteer for those community schemes are older and were shielding themselves, so couldn't carry on working with them. So a number of those have closed. So you can see that in when the system starts to get itself back to to, you know, whatever. There's going to be real gaps in that kind of community transport, actually. So I think that's one of the things we want to look at, making sure that the voluntary sector has got the right support and infrastructure to be able to kind of set those up again, because they're of real benefit to people. I hope that helps answer your question, Mark.
Yeah, it does. I use a similar thing elsewhere in the country, and I think, yeah, that's obviously troubled times at the moment, but yeah, that does. Thank you very much.
Thank you. Any other committee members got questions for Louise? Councillor Butler.
Yeah, thank you, Louise. Your reports are always really lovely to read, very exciting. I had one experience that I wanted to just pass on to you about Poole Hospital, is that late last year, my husband took a neighbour to A&E and had a bit of difficulty accessing the department for somebody elderly. So it might be good if that could be looked at, you know, how far the journey is to actually physically get from the car out of the hospital or out of the ward to the exit. It was quite a difficult route, apparently. So that was just one thing. The COVID, the vaccines have been amazing. In fact, I think there's a bit of doubling up, because personally I found I've been invited by the NHS and the local surgery, and I had a letter as well from the local surgery. So I had 3 potential invites. But the feedback that I've heard from people in Poole has been excellent, especially the Hamworthy Club and the Poole Terminal, ferry terminal. People have been really pleased about how it was all run, very efficient. You know, they felt wonderful, and they've also told other people. So that's helped. And that might help to get trust in having a vaccine for other people, if people can share their good experience. So that's been really good. The one thing I was worried about is in your information, say 10 out of 40 people interviewed for the A&E had long-term health conditions, which worried me a bit, because does that signify that some help is not being given to people to prevent falls, slips and falls? Maybe they need a bit more education or a bit more help with being more mobile to prevent that, because I noticed in the graph that a lot of the age group was older, and also quoted as a quarter of those interviewed. So that was the only worry I had there, really.
Thanks, Fiona. That's really useful, that feedback about Poole A&E. And yeah, I think that when they'd been trying to set the department up so that it was safe for people and socially distanced, it kind of made that journey a bit longer, actually, for people driving themselves to the department. So that is useful feedback for them. I agree with you about the vaccines. We've also been getting lots of positive feedback from people. Some questions about communication. I think some concerns about that, people worrying that they're getting different letters and texts. But I think, having spoken to the vaccine lead at the CCG, they explained that because it's a national campaign, as well as get missed anywhere, kind of not to worry if you get 2 letters, really. But yeah, I think some of that communication, I'm sure, could be improved as the vaccine programme carries on. I'm hoping that our survey will help find ways in which it can be improved. And I'm sorry, I'm not quite sure which graph you were looking at. Which report were you looking at?
Oh.
You said something about the falls. Who was going into A&E with underlying health conditions? Is that right, Diana?
Right.
Yes.
Project.
A&E, yeah. You interviewed 40 people, and 10 of whom were quoted as having long-term health conditions. Yeah.
I think at that time, that was when we were able to go in and talk to people face to face. What a lovely thought that is. Maybe, you know, soon we'll be able to do that again. Yeah, and that was people at random who were accessing A&E, and I guess it'll probably be no surprise to the staff of Accident Emergency that a quarter of the people they see have long-term health conditions. So yeah, I think that explains the high number. It's people who were accessing A&E. It was totally at random. Our volunteers were going in at different times, different days, to talk to people in the department about their experience of why they'd gone to A&E, what their experience of being there, what it was like. Yeah, and I think you'd expect to see more people with long-term health conditions in an accident emergency department than you would in another environment. I hope that explains.
Okay, can I just add one thing? I'm just a bit worried that we go too far down the digital consultation route, because a lot of people have got sight and hearing and speech problems, and you really need to be close to them and see the whole person as well. And a lot of conditions, you can pick up a lot of signs and symptoms that you wouldn't see with just a screen seeing head and shoulders. I'm hoping that as part of this, it won't negate the need for the face-to-face contact in the future. That's what I'm hoping.
I think you're absolutely right. There's definitely a place for digital consultations, and some people who have never used them before have found that and they found it very helpful. I think in an ideal world, that will then free up time for the people who need to be seen face-to-face to be able to access face-to-face primary care services. So yeah, but I totally agree with you.
Thanks, thank you.
Thank you. I believe Sally Sandcraft wants to come in on this. Is that right, Sally?
Yes, if that's okay, Chair. I just wanted to, hi Louise. I just wanted to give a bit of reassurance about that, because I recognise the anxieties, and having a father with dementia and a mum that's caring for him, I absolutely recognise that digital is not for everybody. There is absolutely no intention to only move to a digital solution. There will always be a choice, and there will always be a clinical need to have the facility to have face-to-face consultations with people. So that there is that choice currently. As Louise says, for some people like myself, to be honest, and my husband, my friends and younger family, having the opportunity for digital consultation is really helpful when you're working. But it's, again, for me, it wouldn't be appropriate for everything. There will be a time when somebody needs to assess you clinically face to face, and that is always and will be available for people, and it needs to tailor to individuals. So it is about a menu of choice, but it is also about what convenience that provides sectors of our community by having that digital option, and it's also suitable for some clinical presentations, but not all. So want to give you some reassurance about that, Councillor Butler.
Thanks very much. That's lovely, Sally. Thank you.
Thank you. Have we got any more questions for Louise? No. I share Diana's concerns over the digital. Having some elderly parents who are getting a bit fed up with everything being digital, and had a few choice words about the census being digital, and I had to point out that you can do it with a paper copy. But yes, so I mean I'll be really interested to read your access to the primary care, because that does affect everybody, as to that's our first port of call, isn't it, for most of us when we're not feeling too well. So if no one else wants to say anything, thank you very much, Louise, and we'll look forward to hearing your report at the end of all your reviews. Thank you.
Thank you, Chair.
So can we now move on to item 10, the COVID-19 update, and I've got Jan Thorgood and Sam Crow. Thank you.
So, Chairman, if I just come in and say it's going to be Sam is going to go first, and then David Vitti and Phil Hornsby from Adult Social Care are going to take us through the presentation. So over to Sam.
Thanks very much, Jan. Good evening, Chair. Good evening, members. There is a presentation, I believe, but I don't think I'm a presenter tonight, so I'm hoping that someone will be able to drive it on my behalf, please.
Evening, Sam. Sorry, Joe Tyler, Democratic Services. I've just made you a presenter, so you should be able to share, but if it's easier, I can bring up the presentation if I can find it.
I think because we've all got several slides within it, if you wouldn't mind, Joe, that would be great if you could drive.
Not a problem. If you just bear with me for a couple of moments, Chair and members.
So just while the slides are coming up, I guess I was reflecting on what a difference a couple of months can make, and I'm still taken aback by just how quickly things can turn around with the pandemic and the local situation. In the last committee, we were facing a much more difficult situation, but I'm really pleased to say that the infection rate significantly, our hospitals are treating many fewer people with COVID-19, and I think it's clear that we're now seeing the impact of the vaccination programme, both reducing the chance of someone developing serious disease requiring hospital care, but also perhaps starting to reduce transmission. But it's not all down to vaccination, and I think one of the things that I wanted to thank people for tonight was, if you look at the infection rates currently in BCP Council, they're now down to 38.4 cases per 100,000, very similar to Dorset Council at 33.6 cases per 100,000, and that was recognised by the Regional Director of Public Health as a huge effort, and it's been commented on all of the local efforts that have been made to get that infection rate down, because it does require concerted effort across many different sectors. So again, huge thank you for that. If we could move on to the slides, please, Joe, and perhaps move to slide 2.
Certainly. So I take it that you can see the slideshow there.
Yeah, it's all coming up. That's
lovely.
Great.
Okay, I'll move on to slide.
So as I mentioned, infection rates are still falling rapidly, and it just shows how effective that lockdown is as a non-pharmaceutical intervention. You know, despite the fact that none of us want to be in lockdown, it was incredibly effective at reducing transmission. I've talked about those updated case rates. The over 60s rate falling really quickly now, and I think that in part is due to the fantastic efforts with the rollout of the vaccination programme. I think around well over 308,000 people now immunised across both council areas. So a substantial proportion of the over 60s now will have had their first dose, and we're now moving very quickly to look at offering second doses. The testing positivity is down in our community testing, so 3% last week for the BCP council area. Very different situation to that in early January, where positivity was almost 19%, which is extremely high. But I think one of my other messages is that although it's a much rosier picture, there isn't any room for complacency, and you'd expect the Director of Public Health to say that. I think one of the things that this pandemic has done is surprised us again and again, just how quickly things can fire up. So one of the messages that we're giving consistently is that although it's great that we've got the roadmap and we're starting to think very carefully about how we support the opening up, we just need to hold tight, not go too far too quickly to avoid returning to a more serious situation with a rise in infection rates. If you could have the next slide, please, Joe. Thank you. So I've shown this slide a couple of times, and it just shows the actual diagnoses of COVID-19 under BCP Council. You can see that as we came out of lockdown 2, we had infection rates quite similar to the rates that we have today, and then it didn't take long in the sort of early holiday period for those infection rates to start to take off very quickly indeed. But luckily, the downside of the slope has also been pretty steep. And as I said, that's testament to all of the efforts, as well as the vaccination programme starting to kick in and have an effect. So the aim of the strategy going forward is to avoid at all costs seeing this type of serious peak. And if we could have the next slide, please, Joe. That just shows you the comparisons. This is the actual rate per 100,000 population, showing BCP Council in the blue. It shows just how much higher we went compared with some neighbouring councils, but also reassuringly, we've managed to bring it back down, and actually we're sitting comfortably at the bottom of our neighbours. And it's good that we're not seeing patterns of enduring transmission and continuing to see that fall in case rates. Next slide, please. So as I kind of mentioned under the slide with the epidemic curve, the challenge now is for us to start to think how we support the roadmap and the framework for how we loosen restrictions. There's a rapid national requirement for us to refresh our local outbreak management plan. If you recall, back in the summer, all upper tier councils were required to develop a local outbreak management plan, and that set out how the Health Protection Board and the Local Outbreak Engagement Board would be working through understanding how to support high-risk settings, how we'd be using our intelligence and our testing capability to identify and respond to cases of COVID-19, hopefully breaking chains of transmission quickly. So there's a requirement to refresh that plan, thinking forwards rather than backwards, and to provide local assurance on our capability and capacity of how we'll be able to respond to outbreaks under the roadmap, mobilise some of the tools and the interventions that we now have at our disposal. So if you think about our community testing capability, it was all about PCR testing in the back half of 2020. Since the Christmas period, it's all about asymptomatic community testing as an additional tool in our toolkit. Under both council areas, we've managed to mobilise a fairly comprehensive asymptomatic community testing offer. If you're working for a small to medium-sized employer, you can register to access lateral flow testing as well. And it will be used in earnest as the schools return this week. School children will be tested by school, but of course, members of their household are also being asked to lateral flow test so that we can be vigilant for any asymptomatic cases that might be in the wider household and hopefully prevent transmission as quickly as possible. Enhanced surveillance will continue. We're going to need to be very tightly on any cases that start to come into our line of sight and work quickly to make sure that public health action is being followed to limit the impact of those. One of our roles will also be continued assurance around the coverage of the vaccine. So this huge effort to mobilise huge number of people who are being immunised will leave some gaps inevitably, partly because of the speed with which this has been rolled out. So again, there will be comprehensive work through the Health Protection Board and partners to start to think through how can we support our colleagues who are delivering the vaccination programme to make sure that we close those gaps in uptake. And a very live issue at the moment, for those of you keeping a close eye on the news, is how we plan to make sure that we've got robust plans in place in case we need to stand up surge testing quickly for these variants of concern, which there have been a number that we've been hunting in England recently. So the plan's also an opportunity to show the learning over the past 9 months. And overall, the aim is to show how we will be progressing through the Health Protection Board to more of a business as usual model for COVID-19 mitigation rather than being in permanent incident mode. Next slide, please. And just some final messages from me about the sort of key issues over the next few weeks. It's really important that we maintain confidence in the public's adherence to the public health measures. Just because we have a large vaccination programme underway and we have access to lateral flow testing, that doesn't negate the need to keep the social distancing and hygiene measures going. Until we have more assurance about the impact of the vaccination programme, and until we're assured that we can open up at least through the first couple of stages and keep our infection rates low in our communities, we still need to adhere to those public health measures. So that's going to be a hard message to give, because the natural psychology of being protected by a vaccine is that you may well think that these measures don't have to apply to you, but we're trying to stress that actually it remains a population effort, and it remains that most of us still need to make sure that we're carrying out these measures for them to be effective at keeping cases low. A lot of the focus at the moment is on supporting schools to open safely. I've talked about the lateral flow testing, not just of pupils, but of the household bubbles. Our learning from managing outbreaks in schools over the past few months was that schools are not inherently risky places. Our understanding from outbreaks was actually a lot of the cases that we identified in pupils were as a result of household transmission. So that's why lateral flow testing of the household bubbles is really, really important, particularly if parents are going out to work. So we need to keep our communications lines really clear around the vaccination programme and rapid testing. Neither of those should mean that people can stop social distancing, and we need to keep practicing those good infection prevention and control measures. We need to get our infection rates down further, although we are in a relatively good position with rates of around about 38 or 39. That is still relatively high if you think back through to the back end of the summer. When we came out of lockdown 2, the infection rate in BCP Council was around 50 cases per 100,000. And you could see just how quickly it shot up over the winter period. So we do have to continue to get those cases down and keep monitoring some of the offers that we've made, including the take-up of community asymptomatic testing. So one of the strategies of living with COVID safely is regular participation in that community testing. We need to understand what the barriers are to people taking that up. So far, we've got good take-up of asymptomatic testing across some of our sites, but not all of the sites. So understanding who's coming forward for testing and who isn't will be a really important part of our evaluation as we go forward over the next couple of months. And then finally, one of the most important components will be this understanding of behavioural insights, not just to increase the take-up of vaccine in groups that may be hesitant, but it also has a role in thinking through what are some of those barriers to coming forward for asymptomatic testing, and indeed testing when you have symptoms, because if you have to legally self-isolate, and that's going to present financial difficulties or other difficulties for your families, we have to continue to work to understand what those are and what we can do to overcome them. But on the whole, much more positive than a couple of months ago, and we're looking forwards. We hope that we'll have the draft plan in place very soon, and that will provide us with a really good framework for continuing to support our health protection response as the rest of our local communities start to try to get back to normal. So I think that's all from me. Happy to hand over to colleagues.
Thank you, Sam. Good evening, Chair and members. I'd just like to give you a brief update on the operational adult social care position. Very similar to the last update at the last committee, in that we continue to focus on hospital discharge, and we continue to see a lower demand for respite care than we would usually. This is, I think, almost certainly because people are reluctant either to invite carers into their home to provide respite, or to go and stay for a short period in a care home, just because of the risks. And of course, because fewer people are taking up the opportunity of respite care, we are aware of the pressure on carers who are not getting the breaks they would normally have. We're also continuing to see quite high levels of safeguarding alerts. This doesn't necessarily and fully play out into full safeguarding investigations, but what we are seeing are more people raising concerns with us. And we think a large part of that is the number of volunteers who are working with people who are isolating, because we simply have more eyes and ears in the community who might be identifying things that worry them, and they want to pass them on to us to look into in a bit more detail. And then mental health assessments and demands on our community mental health teams are also higher than usual. And I think probably that's not unexpected, given that we know that one of the characteristics of the pandemic is an impact on people's mental health. Thank you, Joe. Next slide, please. So we're continuing to adjust the way we work operationally. We are visiting people face to face when we need to do that, but equally, where it's not necessary, we are working remotely through things like television and video conferencing, and we're doing that to protect people who are particularly vulnerable from the risk of face-to-face contact with our practitioners. But that's quite successful. We've become quite practiced at that sort of remote working over the last year or so. Interestingly, sickness absence is very low across BCP adult social care. Even now that we're regularly testing our practitioners, we're not seeing a great deal of self-isolation. We're not seeing a great deal of positive infections coming from that testing, although it is very reassuring that we're doing it before we do undertake those face-to-face visits. And of course, PPE is now a routine way of working for us. In terms of services that we've had to stand down, under Care Act flexibilities, which are a provision of the Coronavirus Act from last year, the only one of any substance that is in place is that day centres remain closed. For now, at least, we just don't feel that we can create a safe space with suitable social distancing, particularly when a number of people who go to day centres might, for example, have dementia and might find it harder to follow the sort of instructions around infection control that they would need to in a confined environment such as a day centre. But again, this is adding pressure to carers because we know how valued our day centre provision is, and we hope to reopen them as soon as it's safe to do so. Thank you, Joe. And then there's some associated activity alongside our field work. People leaving hospital or who received care to prevent them going into hospital during the first wave of the pandemic, so that was March to August of last year, received essentially free care after discharge. That was government funded and channeled through our local CCG. All of those people on free care, and there are about 630 of them that we're reassessing as a local authority. Those people are moving off that free care provision now onto longer term care, where they may have to contribute towards their care costs. We're required to do that by the 31st of March, and we're on target to do that. Running alongside it, people with primarily healthcare needs who may be entitled to continuing healthcare, that is funding from the NHS for their care, would ordinarily be assessed to determine whether they were eligible for that funding. That eligibility assessment stopped again during the first wave of the pandemic, began again in August 2020, and we are now working with colleagues at the CCG to catch up on that backlog of people who we need to determine whether they have eligibility for continuing healthcare or not. And then lastly from me, just to reflect on a few of the risks that are still outstanding for us. We're not so concerned as we were about staff absences, but we are still worried about the pressure on carers, particularly because they can't get a break at the moment. And we still worry about the welfare and resilience of our staff, who continue to work long hours, and many of whom haven't had a chance to take any time off or a break. So we are focusing on their welfare as best we can. And then finally, we know there's a backlog of work for adult social care that's built up. It's low priority demand. For example, our occupational therapists have not found it as easy as usual to undertake home adaptations. And we know there are probably a lot of people who do need some care and who haven't come forward to request it because they're nervous about care staff coming into their homes at the moment. So we would expect, as the pandemic subsides, more demand on adult social care as these people come forward, because they'll be feeling more confident about asking for care. Thank you, Joe. That's all from me, and I'd like to hand over to Phil Hornsby to provide a commissioning update.
Evening, Chair, members. Thank you, David. I thought I'd just start with an update around the grant funding that we provide, whether they're contracted with the council or are independent of the council's commissioning. And so we've continued to send out the additional grant that's come to us. That's workforce capacity funding and rapid testing grant. But all of those, including the infection control grant that started last May time. And just for members to be aware that we've issued just under £16 million worth of grant, including money that the council funded for the first few months of the pandemic between March and June. What we found that we've still had the need, and working with the clinical commissioning group, to provide ongoing infection and control training. There's a turnover of staff in the independent sector, so new staff come along, or refresher training for those who remembered every element of infection control. And we're still offering that, and it's still being taken up in numbers, not in huge numbers, but the training is still happening. We continue, or well, rather Jan and Sam do continue to write to all providers on a weekly basis with advice, guidance and updates on key issues that affect them and affect us as the pandemic continues. And we've been supporting staffing shortages, mainly the care homes had, although this is much reduced. And it's been work with the Local Resilience Forum and the Rotary Club have been coordinating requests for support by care homes to act as a central point, and that's taken the pressure off providers to have to ring agencies or ring around others to try and find staff if for any reason if they've got some sickness or they can't fill a shift. We haven't stood the Rotary Club down, but we're finding that there's less and less demand on them, so they're just sitting in the background. They're still there if required, but we will review that in a few weeks' time. Volunteers, including BCP elected members and council staff, have been volunteering to work into care homes. They've been trained and deployed, and there's been a good take-up of those volunteers. And we've been, although this again is much reducing as the national coordination of vaccines rolls out through primary care networks of GPs and through the large hubs, the mass vaccination hubs such as the BIC. We have still been coordinating vaccination, particularly around social care workforce, but also providing information back to central government around informal carers, those that we're aware of, those that we've been working with and we have in our books. And I just thought it was worth mentioning that after what is now a year of dealing with the pandemic, that we've got a lot of staff both within our own services, those that we commission, and the NHS, who have experienced high levels of stress and distress over many months now. And for quite a while, Dorset Healthcare Trust have been providing a wellbeing service for staff to refer themselves to for support. And it's not, we wouldn't call it counselling, but it's support. It's just someone to talk to and to signpost them to other services that can help them if they are suffering from that stress and anxiety. Joe, thanks. Next slide, please. If we just focus in on the care market itself, then just as I've just mentioned that last bullet point on the slide before, social care leaders are saying that they are seeing high levels of emotional stress right across the sector, particularly with care home managers, but equally it applies in the domiciliary care sector. But care homes themselves, because they've seen a lot of deaths, they've seen a lot of people very ill, and they've seen their own colleagues suffer with COVID. So that is a concern, and we continue to work with them to support them. You may recall, members, last time that I reported quite a high number of care homes who had infection outbreaks. I'm pleased to report that that as of Friday, we were down to 23 who had ongoing outbreaks, and therefore a suspension on admissions to those homes. And just as a reflection, if we went back to the 8th of February, we had 78 care homes who had a suspension because of outbreaks. So that's really coming down quickly. We're seeing that number continue to decrease with very few new outbreaks happening. Just in general availability of care across BCP, that's good, but we are noticing that cost is still rising. A lot of that's linked to the additional requirements of COVID that aren't covered by grant. Some of that's just additional staffing to cover the support needed to people who isolate, or just the general upkeep and social distancing within care homes. They do use the grant for those to cover some of those costs, but it isn't necessarily sufficient for all costs incurred. And I just thought to mention that whilst all of this activity around the pandemic is going on, we are still continuing to work with the sector to develop our commissioning activity for the future, which is the development of commissioning strategies for older people's care homes and extra care housing for all adults. And then a final point for me, the national guidance on care home visiting changed today, and that's to enable increased levels of visiting to families to access their relatives in care homes. But I just want to put that, whilst it will support the well-being of residents, it is based on a risk assessment by the care home about how they can safely manage that. And as ever, we want to keep that risk as low as possible while still enabling people to see their loved ones. So I think that's the last slide. Jo? Yes, thank you. And I'll hand back to the chair.
Thank you. Committee, has anybody got any questions for Sam or Phil? Perhaps I can ask, how are we doing with the take-up of the vaccination? I think that's a question for Phil. I think Phil Hornsby.
Well, there was me hoping Sam could answer that one. Last week we were up to by the staff themselves, were you saying, Chair?
Yes, because I believe there were problems because if they had COVID and that, they weren't necessarily going for their vaccination. And I just wondered how, if we'd improved our uptake on our care home staff and our carers having their vaccination.
Yeah, okay, thank you. Just in terms of percentages, we were up to the back end of last week's, I think it was Friday, we were up to 68.2 or 68.3%. However, we just need to bear in mind that a number of staff have been ill. I mentioned all the care home suspensions, so we've had quite a significant number of staff who have been absent due to COVID, and therefore they couldn't take their vaccination at the time. So a number of those that remain will be picked up in that. However, we do know that there are some, and it's a relatively small number, but it's still significant, of staff who have chosen not to take the vaccine for their own reasons, of which they feel very strongly about that, and which might be a religious or a cultural or just the fact that they're not convinced that it's the right thing for them to do. So there is work going on, supported by public health and led by public health, that Sam might, I don't know if it's worth commenting on around the support we're giving to encourage staff. Sam?
Thanks, Phil. Touch on it very briefly. So the public health team is trying to use a combination of behavioural insights and just asking people what might be the barriers and why they might be hesitant in coming forward. And a lot of the intervention is actually just being very, very clear and reassuring about sort of walking people through the steps in the development of the vaccine, the way that they're tested, the sorts of trials that have to be done, and the sorts of side effects that you might see in those trials, and then finally the sort of assurance process around how vaccines are licensed and the role of the Medicines and Healthcare Regulatory Authority. And as a result of that work, the CCG has an excellent page where they identified a number of people from different settings and different walks of life who've agreed to come on camera, as it were, and to make some very, very short videos giving their own perceptions of why it's important for them to come forward and have the vaccine. So I think through a combination of understanding what the barriers are, having an honest and open conversation about those very short video clips, we're aiming to try to increase the transparency and the understanding of the importance of vaccination, and hopefully not see too many of those gaps continue.
Thank you. Councillor Andy Jones, I believe you have a question.
Yeah, thank you, Chair. This is a question for Sam. One of your slides earlier on mentioned about surge testing on variants of concern. I just wondered how this would be implemented, and I guess what it would actually look like on the ground in terms of obviously what would need to be done across the BCP area.
Thanks, Andy. So I think it probably very much depends on the situation. One of the pieces of work that we're doing with the testing cell is to look across all of the postcode areas across both councils, and to work out that if we had to identify and test people within particular postcodes, what would be the best testing capability. So, for example, we've got a number of mobile sites, but we've also got a short list of sites that could be deployed in case National sent additional testing resource at short notice. You know, one of the tactical and operational issues is where are you going to put these mobile units if they come. So that thinking's already been done. In terms of the nuts and bolts of how we would stand that response up, we'd be working very, very closely with Public Health England and the Regional Health Protection Team. But on the ground, it would be a combination of the LRF Tactical Coordinating Group, which is agreed to hold the ring on the plans and to conduct our readiness exercises. Depending on which councils this is in, whether it's BCP Council or Dorset Council, we'd also be obviously involving the incident management teams of both councils. So the plans are in preparation. We've got our communications plan ready to go. It's very much just a kind of case of being ready if and when, and knowing how to mobilise, particularly out of hours. That's the really important part of this. It's okay having a response in daytime, but doing this at the weekend or you know, of an evening, if you're kind of notified for very, very short notice, that's what we need to make sure that people are primed and ready to act on.
Thank you. Any more questions, Andy?
Yeah, just to come back on that, obviously, you know, Sam's gone into detail then about what we would be looking to put in place if a situation like that arose. Are we confident we've got the right level of resources to make that happen, bearing in mind obviously what's already taken place on the ground at the moment?
I think we have, and one of the things that we've learned from the response over the past year is just how quickly we've been able to redeploy people at short notice, and the role of that, the Local Resilience Forum is really, really key, being able to mobilise people on the ground very, very quickly. You know, this would be an operation that's done hand in hand with National. So in all of the areas that have been required to stand up so far, it's National resources working hand in hand with local delivery that's been the effective. That's what has been important in sort of delivering an effective plan.
Thank you.
Thank you. Councillor Roberto Rocca, I believe you have a question.
Yes, thank you. Is a question for Sam, please. I had the question. The first part of the question was about which type of strategy you got on with the test center, but you already answered with Andy. I got a question about the vaccination center, especially in particular about BAC, because I understood that there are a lot of vaccination in the GP surgery around the conurbation, and the BSc I heard that is is not used a lot. So I want just a clarification if there is any plan to rely on only on the GP and then close the BSc, or we will keep open BSc and that there will be you know, both solution. And also, I got a second question that is just a curiosity, but because I know that in the test center, you have to test to swap by yourself, and then there is no help from people in the test center. And how much are reliable these tests done from people that maybe are not very, I've done a few times in the hospital for different reasons, and I can see how it should be. But are people doing well? So is there any type of check with the test? Thank you.
Thanks. I'll take the first question quickly. I mean, I'm not responsible for the delivery of the vaccination programme. That's colleagues in Dorset CCG. My understanding is it was always a combination delivery model. So using primary care networks to deliver the vaccine, as well as having a major vaccination hub, was always going to be an important part. And if you think through where we are in the cohorts, that's going to become increasingly important. So there may well have been times where it looks as if the BIC was underutilised, but when we start to reach into the working age adult population, there'll be more and more of a requirement for perhaps a bit of convenience around appointments, perhaps coming to the BIC at weekends or out of hours. So I think continuing to have both the BIC in play and the primary care network sites will be important. But I'm happy to take that to Dorset CCG colleagues if they want to give a more detailed response. And then your question about testing. Yeah, testing has really evolved, is probably the simplest way of responding. So there's a difference between perhaps the level of expertise required to take a swab for a PCR test, which is done when someone's symptomatic, compared with the sort of swab that people would take for a lateral flow antigen test. And as experience with those tests has grown, the government and the testing, NHS Test and Trace, appears to be much more confident about what's called assisted testing, where someone may watch you take your own swab, or even the use of household test kits. So once you've watched the video, you kind of have a go at either swabbing yourself or watching other members of your household take their own swab. I think in terms of the number of voids that we're seeing, particularly in relation to antigen testing, they appear to be fairly low. So I think on the whole, we're sort of fairly confident in the ability of most people to get a reasonable swab back for the antigen testing. So it's just important to bear those two differences in mind. The PCR swab testing is, on the whole, still done by professionals.
Thank you.
Thank you. I can tell you I had my vaccination on Saturday at the BIC and it was quite busy and there were lots of volunteers there and it all ran very smoothly. Yes, it was, I can't believe how quick actually having the jab is. It was sort of, you don't feel a thing. Councillor Diana Bottler.
Thank you, Chair. It was just to ask, do we know when the teachers will be called to have their vaccination for COVID?
So I can ask that question of Dorset CCG, but I imagine the answer will come back that they'll be called in line with the rollout of the national 9 priority cohorts. So the Joint Committee on Vaccinations and Immunisations has said these are the sort of first 9 priority groups, and we're trying to be as much in line with that as possible locally. So you'd be called on the basis of age and underlying clinical conditions in line with those clear priorities.
Thank you, Sam. Can I call in Sally Sandcraft because she's raised her hand. She may be coming in on that, Diana.
Thank you. Yeah, taking it back, I thought it'd be helpful just to respond to both the question about the combination of the GP-led services and the BIC, and then subsequently around the cohorts of people that are being vaccinated. And both answers are similar in a way. I can't overemphasise how much this is a national-led programme that we are delivering locally. They are that the command and control around the routes of vaccination, the supply of vaccination, and the cohorts and the order of the cohorts of people in our population that are being vaccinated are absolutely very much being led by the national direction on that. So there is no leeway for local determination of that, and I can understand in some ways why. And there's been lots of discussion about do you focus on groups of the population that might reduce transmission versus the groups of people that have the virus and have the effect of the virus more severely than others. And the strategy nationally has been very much to focus on the cohorts of our population that if they get COVID, have more severe reactions, end up in hospital, etc. So it's been very much on that approach. Now, that's not to say over time, as time goes on and those cohorts of vulnerable people get vaccinated, they might not change the strategy to more one of reducing transmission, but that is not the national policy at the moment, and we are very much needing to, we have no leeway other than to work to the national direction, because the supply of vaccines is very much monitored in terms of the cohorts of our population in which we're administering. Similarly, in terms of the big vaccination centres like the BIC, they were nationally commissioned through us in Dorset, and if they decide to make any changes to those national delivery centres, it will be very much a national decision with the understanding about what the uptake is. And as you've experienced, that our GPs are having some frustration, as are some of our people that live in Dorset, around more than one request or invite to go for a vaccination. But the BIC is part of the national centres that are getting nationally driven invites, whereas the primary care networks are locally initiated invites linked to the cohorts of our populations of priority. And then people are choosing by their feet, really, in terms of where they then go and have their vaccination. But as Sam said, the big cohorts of our population, which we're now entering into, you could argue that we're going to need all the centres open to be able to respond in a timely way to get people vaccinated quickly. So I can't overemphasise the way in which this is nationally being managed. Thank you.
Thank you for that explanation. Have we got any more questions from members? No? Well, thank you very much, Sam, Phil and David, for that. So we'll move on to agenda item 11, which is the portfolio holders update. So if I can ask Councillor Nicola Green. Thank you, Nicola.
Thank you, Chairman, and good evening, members. I shan't say too much because one of the benefits of going straight after the Director of Public Health is that everything's been very comprehensive. But just a couple of comments from me more generally around my portfolio. But I would just like to start on that, the point about the primary care networks and the BIC and the apparent overcapacity that we've got, and just perhaps reflect that it's not very often that we sit, particularly in a scrutiny meeting, and think about an oversupply or too much success that we've actually got going on now. Just to take you back from the time to the time when the BIC was being planned, as Sally said, it's a nationally mandated programme, but it wasn't quite clear, I don't think, to us all what the capacity and the interest of GP surgeries would be, and they have absolutely embraced this, working through the primary care network, and certainly to many of our elderly population, that's been an incredibly welcome thing, to go to their, if not to their own GP, to somewhere that's recognisably part of their local community, and have their jab there. And I'm sure that's been that's contributed to the terrific take up that we've had in our most elderly. But I absolutely endorse what Sam says, that I think as we get more into the working age population, the mass vaccination centre and the flexibility of time and weekend working may well serve that community, while the GPs continue to do what they've been doing so brilliantly so far. Where we do have something, I think, to some further work to do, we need to be honest, is on reaching all our communities and ensuring that we get equal take up of every different group across BCP. There's been an awful lot of targeted comms that Sam's drawn your attention to, but we really need our trusted voices to reach out into some communities and be advocates for the programme. A lot of good work's going on there, but it's something that we mustn't be complacent about. Just something that hasn't come up, so I'll make two further points if I may, and one is around the testing in schools. Clearly, I've been corrected a number of times, and school leaders are always very keen to say that we haven't reopened our schools today. Our schools have always been open, and they have been providing, school places for some of our more vulnerable children, but clearly a very large number of key workers have had their children being able to be educated in a more recognisable way for us. So they have remained open, but as we move to full reopening, the testing programme is really ramping up. We've used that a number of times over the past year, but this again is a significant step up in the capacity due to the nationwide system. And the plan is for children to be tested a few times in school. And this, I think, refers to Councillor Rocker's point about the efficacy of testing, that it will be done a number of times under supervision. And thereafter, that should bring out any problems with the young people doing the tests, and thereafter they will be able to do them at home. But they will also be doing testing for their families. And I think as we move down the age groups, we need to be quite clear that just because you have had the vaccine, it doesn't mean that you are fully protected. We know the figures and they're very encouraging, but there is clearly still a risk. So for the community, whether you have or you haven't been vaccinated, your approach to testing should be the same. And then just lastly, the point I wanted to make, Chairman, although I'm very happy to answer questions, of course, is to update the panel on the fact that we have a very significant number of people who are still regarded as clinically extremely vulnerable. You'll be aware of the group who was shielding from very early on in the pandemic, and the number in BCP was about 15,000. Well, in the very recent past, as the medical guidance has changed and has expanded, that's meant that there are another 11,000 people within the BCP conurbation. So as you can see, that's really quite a significant number who are having to take that approach. Now, a very large number of them will be coming forward for vaccination, but going back to what I said earlier, they still need to take the same precautions as the rest of the population post their vaccination. There is support on offer to them through the Council's community response, which is the Together We Can programme, which I've sat in front of you many times before and spoken about, and we'll use every method to reach out to let people know that support is there. What we are noticing is that the requests for help are very low in number, and I think that's great credit to to the whole population actually, that the resilience amongst those people has grown enormously. We've all got more used to online shopping, but also I would like to pay tribute to the volunteer cohort. They've been tremendously active through the vaccination programme, but also really since the very beginning of the pandemic, they stood up and reached out to a lot of, can you stand up and reach out to a lot of people who need that support of prescriptions collecting, groceries and so on, and many of those relationships have been long-standing. So I say very happy to answer questions, Chairman, if you would wish, but I won't take your time up any longer. Thank you.
Thank you, Councillor Green. Have any members got any questions? No, I can't see any hands raised, so I'll go over to Councillor Karen Rampton, please, for her report. Karen?
Yeah, thank you, Chair. I hope you excuse me not putting my camera on, but when I press the camera button, I actually look as if it's the Blair Witch Project film, and I don't just mean my hair, which is, you know, gone mad like everybody. So I don't quite know what's wrong with my Teams at the moment, but hopefully you'll allow me to be unseen but heard. So Phil covered a couple of things that I was going to say about the marked reduction in the COVID suspension data. Great news. And I think he also mentioned about the care homes. From today, a single name visitor can go to the care home. They have, of course, got to follow strict infection controls, and that includes doing a lateral flow test before each visit and obviously wearing PPE. Another thing, I'm not sure that this was mentioned, was about our free PPE offer to carers, which is now in operation. There was a blip last week. I think the demand outstripped supply in a couple of places, but I had a call today actually from a carer who was absolutely delighted that that was all sorted and she was going to collect hers tomorrow. So that's going really well, and obviously that is an offer which is very welcome and has been taken up by our carers. So just a couple of other bits. I know it's getting a bit late, so I won't bang on forever. There is a live consultation happening at the moment on the way that CQC about them changing the way it assesses and rates NHS and social care. Not sure we will respond as a council, but just wanted the committee to be aware that that is happening at the moment. There's also a consultation on proposed new Mental Health Act legislation, and that has a closure date of April. And if it's implemented, that could be next spring. So I wondered, Chair, if you wanted to sort of wanted me to mention this, as it could be an idea to have an informal session that certainly our champions, we've got Councillor Fear, the mental health champion, Councillor Butler, disability, and of course yourself as dementia champion, and maybe Councillor Bobby Dove as our equalities lead. We could perhaps have a session, and if any other members of the committee wanted to join that as well, we could consider a response to that consultation, and also of course any implications for the council. So if that's something that you'd be interested in, I'm sure we could set that up in good time to respond before the closure date in April. And I don't have the exact date, I'm afraid. I've just got April at the moment. Not really a great deal else to say apart from the Adult Social Care Contact Centre. It's got some different operating times. I just wanted to inform members of that. So it's now open Monday to Thursday from 9 till 5 and Friday from 9 till 4:30, and that's when the email is monitored and the calls are answered. So this is our contact centre was Pool Help Desk and Bournemouth and Christchurch Care Direct, and they've now merged into one team across BCP. The number for it is 01202 123 654. I don't actually have the email address to hand, but it will certainly be up there on the website should anybody wish to access it. So I'd just like to say that's really great news that that's all come together on time as one, and I'm sure it'll be well appreciated and well used. Happy to take any questions, Chair. Otherwise, I will stop there.
Thank you, Councillor Rampton. Has any members got any questions? I can't see any hands going up, Karen. So, yes, Councillor Mark Robson.
Yeah, hi, thanks, Chair. It's probably a question really, so it might be one for Ben, but I was just wondering how many parents are aware of where to get the lateral flow tests and that they are actually available for them to take. I only say that as a parent myself, and I only found out through the grapevine, not through any sort of real official source. So I was wondering how many schools are aware and can inform parents where to get their test kits from.
Chair, that's probably one for Councillor Nicola Green rather than myself, as it's to do with children and schools.
Thank you, Chair. I'll give it a go. Councillor Robson, it's I don't have a definite answer because each school is dealing with it differently. So my sense would be go to your school, their websites. I know they're handling it differently, but that's probably your best and your first source. And if you can't get through there, perhaps you'd like to come back to me, and I'll follow it up through other means. But generally speaking, I think schools have done a pretty good job of sending out communications. I think one of the problems is that they may have sent out very many communications, and sometimes things have got buried, but that would be certainly the first place to start. And as I say, if you can't, do get in touch with me.
That wasn't really a question. I want to know whether the schools have been informed. The school has been fantastic all through this crisis with information. That was one piece of information that didn't come out, which rather made me thought that they didn't know. I don't need a response now, but it was just for information really that it came via other sources rather than through. So I was just wondering how many of those parents are, taking it up and getting tested, so we can get on top of the carriers that asymptomatic, whatever.
Absolutely, and certainly that's the intention. Sam's just put something in the chat bar, which you might find that helpful, that the schools are sending out the letters. But you're quite right, this is really important because this will have massive reach, really massive reach in a way that we haven't had yet. Too early, I think, to be getting any information back. But we will get some narrative stuff from individual schools, and then we will follow it up and see what stuff is returned to the council via Public Health Dorset. But it may well be that it's dealt with again on a national basis, but we'll pass back any information that we think would be helpful.
Yeah, great. I know it's early doors on that, and yeah, Sam, thanks for that message in the bar there. Thank you.
Thank you. If there's no more questions, we'll move on to our last item tonight, which is our forward plan. Mark, would you like to turn your microphone off? Thank you. I'd just like to add that there's a couple of items that we want to put onto the forward plan. One of the ones was I was made aware that we are having a carers strategy, and there could be the option for this panel to be part of that, of a working group for it. So I'm not sure if Jan or one of the other officers would like to just say something a little about the carers strategy. Thank you, Jan.
Yes, I'll just say briefly, Chairman, we've had a carers vision and a strategy. We have a carers vision Pan Dorset, and there is a Pan Dorset group which includes carers, which has developed the vision that we've had to date. We have had a carer strategy which ended in 2020, and during the pandemic we haven't been able to develop the further update on the carer strategy. So there will be a piece of work this year, both to develop the Pan Dorset vision, and then BCP Council and Dorset Council will have their own strategies. So one of the thinking was that rather than just receive a strategy for comment once it's been produced, that the committee might want to have a working group of a smaller group of members working with the officers, and indeed on occasion engaging with carers about the development of the strategy. So that was the proposal.
And do we have any committee members who would like to think about that and possibly be part of a working group? Don't have to let me know in the next few minutes. You could always email me and we can take that forward. Thank you, LJ. She's put her name forward. And the other one that has been mentioned to me, and this came from Councillor Andy Jones, was dentistry. So I'm not sure if Councillor Jones would like to expand on that.
Yeah, thank you, Chair. It's good to have the opportunity to chat this through with you very recently. I've been contacted by a couple of residents in recent months, and I know there are others are concerned about the difficulties that they're having in registering for an NHS dentist, particularly when they require urgent treatment. I'm quite concerned about this. I'd like to find out a little bit more about how big an issue this is across the BCP area. It's certainly an issue in my own ward. And I think not only that, what some private providers are actually charging for treatment. I was made aware of one particular case recently where if somebody managed to register for an NHS dentist, the treatment would have cost them £50. They were pointed in the direction of a private practice, and it was going to cost them nearly 250. So nearly 5 times the amount of what an NHS dentist would charge. I mean, clearly this is totally unacceptable. I mean, particularly for people on low incomes, are obviously therefore not able to access dental treatment and obviously be able to afford to pay for dental treatment. So I'd quite like a piece of work to be done around this to give the committee, better understanding of exactly what is happening here, how big a problem this is, and most importantly, what we can do about it. Although I accept it's probably not going to be, a quick fix.
Thank you, Councillor Jones. We'll certainly have a discussion about whether this is a piece of work that can go through our committee. So can I ask, is there anybody else got any questions on our forward plan there? We've got adult social care, point of first contact service for our next meeting, and a big plan update. Then later on, we've got social care developing market statement, care home strategy, extra care housing strategy, Dorset CCG mental health rehabilitation service, dementia services review. I believe the new dementia services is to be implemented from the 1st of April. So we'll look forward to an evaluation of that sort of in about 6 months or so time. And then several other ones sort of going on later into the year. Councillor Wilson, did you still have a question?
Yeah, it was just to support what Councillor Jones was saying around that piece of work. I think that is quite an important piece of work that could do with looking into. I've heard similar stories from people anecdotally, not necessarily through my inbox, but just having chats with people about it. So yeah, I'd be quite interested in that as well.
Okay, thank you, Councillor Wilson. Anybody else got any comments? No? Well, I think we can bring our meeting to a close. Thank you, Joe. And I'd like to thank everybody for taking part tonight, especially those officers and those from the CCG, etc. Thank you.